Hey, good morning. This is Steve Stites, Chief Medical Officer here at the University of Kansas Health System, broadcasting live with you from the Dolph Simons Family Studio. Delighted to be back with you this beautiful spring morning. Man, I was just telling these guys I was trying to get out of bed. I was sleeping really, really well, and then my alarm went off. But there was a flash of lightning and a little bit of rain, and instead of getting out of bed, I may have stayed in bed. I think rain and lightning are the cure for insomnia throughout a pandemic. But we're going to be talking to Dr. Nancy Olson today, a pulmonary critical care doc and sleep specialist. She was on our program before, and we addressed coronasomnia. Oh, boy, I got to let me try this one again. Coronasomnia. Coronasomnia, basically the problem with lack of sleep during the epidemic caused by SARS-CoV-2. That was a great conversation. There are a lot more questions than we could answer. So we're going to go back with her today. She's back to talk more about that. And she's going to pronounce this word, coined to talk about sleep deprivation. But first, Doc Hawk is here, our Medical Director of Infection Prevention and Control.
Yeah.
Doc Hawk.
Hi.
How are you?
I'm good.
Good. You were on the phone when you got down here this morning. You were on the new therapy call, weren't you?
We were on, yep.
Yeah. What great things did you learn?
We were just really discussing the tocilizumab use, which is one of the drugs that we would use if you have more critical disease, and also the anticoagulation, which is the blood thinner drugs. Just making sure that we are up to date on the most relevant information and treat you as you needed to either protect you from getting those blood clots that we know happen so commonly, or if you do have those, treat you with the right amount of blood thinner. So
yeah, good stuff. So how are the numbers today?
Numbers today, still pretty good here at the health system. 8 acute infections, 3 in the ICU, 1 on the ventilator, and 14 in that recovery period. Hays, unfortunately, though, we saw a little bit of a bump now. 3 active infections and 1 in the recovery phase. So they were hanging out basically that 1 active, 0-1.
Well, but still 3 is better than where things were. And what was the number of active today?
Their number of active was 3. We have 8.
So really pretty good, darn good numbers overall.
We're pretty happy about it.
All right, before we talk to Dr. Stewart about coronasomnia, I got it right that time I practiced while Hawkeye was talking. That's why I had to ask him the acute numbers again. I was practicing that word in my life. Let's first see if there are reporter questions out there.
Good morning, Cody Holyunk with Channel 9.
Hey, Cody, how are you?
Hey, I'm doing all right. How are you?
Good. What's going on?
Well, we're seeing that it's potentially, or it's possible that America could hit 50% vaccinated adults, at least with the first dose, by the end of the week, my producers tell me. I'm curious your thoughts on that, and, just a reminder to people, how many adults, vaccinated adults, percentage-wise, is it going to take for us to get to that normal point, or at least the light, closer to the light at the end of the tunnel, I guess?
Okay, well, hold on to your hat. Here's my response. Celebrate good times. Come on. Bump, 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 bump. But not really. You can't celebrate yet without your mask on because we got to get to 80% of people who have had 2 shots. But this is really good news to even get 1 shot, because what we know is that 98% of people or whatever who've gotten their first shot get their second shot. So that is great news, Cody. So I'm thrilled about the numbers. I've seen some of the rises in the New York Times. I'm still waiting on the 2-shot thing to get over 20%, which will still be a big thing. But we need to make sure everybody gets their vaccine. And we're going to talk a lot about this at the end of the program, because we are opening up to all Johnson and Wyandotte County residents, whether you're a patient of ours, to come get your vaccine here. We hope to open up to everybody very soon, but right now we're opening up to all Johnson and Wyandotte County residents. You're going to see more information about that in just a moment, or at least toward the end of this program. But Cody, I think it's great. I think it's been talked about here in the last 24, 48 hours with some CDC data, Hawkeye, that says 1 shot still gets you 80%, 2 shots is 90% of Pfizer and Moderna.
Yeah, and I think another important thing to remember is, of course, herd immunity or population immunity. You have to include the other group of people that can potentially get infected and spread the disease. And that's not just the adults, that is the children as well. We know that they can reproduce in the same viral loads, the same amount of virus that adults do as well. So really, we aren't vaccinating that group yet as a whole. Certainly 16 and above is what has been emergency use authorized for the vaccines, but that is another whole group that needs to be vaccinated as well. Overall, I think the numbers are a lot better, and we have been steadily increasing towards higher percentage to gain that population immunity. But right now, got to continue still to do the masking, the distancing, not meeting in large groups, do all those important things that we've talked about. Because as we've seen before in the Swiss cheese model, it's not just one thing, it's a number of different things.
You know, I was listening this morning to a New England Journal of Medicine podcast today about vaccination in black and brown communities, and it was a good podcast. And one of the points being, how do you convince young people to get the vaccine? And they said there really are two key things that you need to stress. One is, and it does look like vaccination helps prevent long haul syndrome, because you don't really get as sick and you don't have some of the problems that you would have otherwise. So long haul syndrome is a little more indiscriminate, whereas young people may not become as critically ill or be in the hospital or die from COVID-19. They're still very able to get long haul syndrome and have some of the long-term complications and sequelae, and you don't want that. And number two, you don't know who you're going to take it home to. And I think, or into your community, and think about who else you're going to affect, especially if you're asymptomatic. The good news about the vaccination is not only does it look like it's incredibly effective at preventing disease, emerging evidence at preventing long-haul syndrome, but there is strong evidence now that you don't transmit the disease if you've been vaccinated, or the reduction of transmission is over 90%. So that is remarkable data, and I think really should be the reason all of us want to be vaccinated. Is we're in this together, and if we're ever going to get out of it together, and by out of it I mean really back to normal, to do that we have to get everybody vaccinated, regardless of age. We need more data in young people to know that it's safe, but I think that's emerging from Pfizer now and quickly. Moderna soon to come. And as we see that information, I'm very hopeful that by the opening of school next fall, that we'll have enough information, but we're going to immunize people 2 years old and older.
Yeah, that's exactly it. You know, as many people as possible. Again, not only to help reduce hospitalization and death, but help reduce sick days, staying home from work, and transmission to other vulnerable people in the community who may not have had the ability to get the vaccine yet. All that will play a role moving forward.
So Cody, I'm back in the chair, and hopefully that long-winded answer got to the points you needed us to make.
Yeah, no, I appreciate it. One quick question, though. Are you seeing from where you guys sit a change in hesitancy? Are more people warming up to vaccinations? I know that you said it's about 70% at the health system. What are you seeing?
Yeah, so our employees, I think we're at 84% vaccinated now, so that's good. So we still have some folks who've not. We have not required it. You know, there are some health systems that are. Oh gosh, I think it is Texas Methodist. Don't quote me on that. But I believe that's right. That is going to start requiring vaccine for all employees, with some exemptions. But we have not made that decision yet. Is hesitancy getting better? I think the more we talk about it, and the more success we have, and the fewer the problems of side effects that occur, I do believe we are going to see less vaccine hesitancy. And I think we're starting to see it ebb a bit. You know, the other group that we have to talk to more are some folks who, especially in rural communities, I mean, we've talked about black and brown, but rural communities also struggle with vaccine hesitancy, and in part it's not as affected folks as much, although the variant that appears to be out there, the variants may change that more, especially in rural areas. But I think that with time and with success, like influenza vaccine, hopefully we will see less and less hesitancy with that. And I think as you watch people who have been vaccinated return to life in a more normal fashion and do well and not get sick, which will be different than those who have not been vaccinated who want to return to life. They are going to get sick. I think that there will be more and more that'll work better. And the other major thing, there was I read a study last week looking at, and I'm not, this is not a criticism, it's just this is the results of the study, and I think it's really important to talk a little bit about. If you look at what was called Trump Republicans, who tend to have tend to have more vaccine hesitancy, who was it that they would most listen to become vaccinated? And it wasn't the former president. It wasn't a talk show host. It was their doctor. And I think one of the problems that we have right now is that because the current vaccines can't be delivered through physicians' offices, by and large, due to some logistical issues, we've taken out a little bit of the relationship between the physician and their patient and the ability to vaccinate in the office. I know we're working on strategies now to address that, because I think that's the next thing. And I honestly think it's not just a Trump-Republican question. I think that's a question of people need to be able to talk to someone who they believe in, because they don't trust the media. They may not trust government, but they do trust the one-on-one relationship they have with their physician. And that's a really important statement. And we need to find better and better ways to get shots into offices so that docs can deliver them, and that doctor-patient relationship can be used to help explain the vaccine and to help get people vaccinated. I think that's really important, and I think that's going to be true, again, across a broader swath of people than to look at a political divide. I hate to look at, and I hesitate to look at political divides, but that's what the study was quoting, and I wanted to make sure I quoted that accurately. Do you have thoughts about, do you have any idea about, because I was gone last week, have we talked any more about getting vaccinations into offices?
Yeah, there was, on our most recent state call for vaccine preparedness, there was talk now about starting to work on getting the allocations to the private facilities, whether that's the health systems or private clinics. So that is coming down. Don't have an exact time frame, but they are working on that. And of course, we still need more vaccine supply to be able to get those into the health systems, the hospitals, the clinics.
Thank you.
Other questions? All right. Let's turn to Nancy Stewart. Nancy, did I call you Nancy Olson earlier?
It's okay.
I know Nancy Olson from a long time ago, married one of my best friends, so I'm sorry I did that. And my med school roommate, as a matter of fact. So anyway.
No worries. It's your chronosomnia.
It is coronasomnia. Thank you. After I blundered that word, I sat here, as I said, well, Hawkeye was talking and tried to rehearse that in my mind. I'm glad you said it just now. You've confirmed I finally got it right after a little bit of time. So talk to us a little bit about what's going on out there. When you were last on, you had submitted some data on publishing from research around sleep habits of folks during the front lines of the pandemic. Where are we with that? Help refresh our memories. What did you find in that study?
Yeah, thank you for asking about it. So that was a international study, actually. We weren't planning for it to be international, but it was picked up because we distributed it over social media. And so we distributed it via Facebook, via Twitter, as well as via email. And we had folks from nearly every continent respond to our survey. And it was geared towards folks 18 years of age and older, looking at folks that are working on the front lines with COVID-19 patients. And we had almost 1,000 respondents. And what we found is that a lot of the respondents, over 90% of the respondents, had reported that they had issues sleeping. Over half of them reported they had issues with anxiety and with burnout. And interestingly, more women than men responded to the survey, and so therefore more women than men were reporting these symptoms. But folks that did not have a significant other also had higher insomnia and higher rates of anxiety and burnout. And then folks with families at home had higher rates of this. And not surprisingly, we did see folks that were of African American descent, as well as Hispanics, that were reporting higher rates of insomnia, anxiety, and burnout as well.
Yeah, it's been tough. So what's the relationship between the pandemic and insomnia? Is it just the stress? Talk to us a bit about what that is.
Dr. Stites, I think it's just stress in general. I think that everybody almost everybody is dealing with some layer of anxiety and stress at baseline in today's society. And then you put a pandemic on top of that, and our bodies are just going, what the heck? Like, how are we supposed to deal with this? And I think that has been evident, at least in my own circle, that I have seen unfortunately, multiple people committing suicide, multiple people losing their jobs, multiple people going through divorces. I mean, it's really impacting everyone.
So really, you're saying that Facebook and Instagram and other forms of social media mixed in with the pandemic, loss of faith in government and institutions, and then economically hard times, all those things might cause a little bit of stress here and there.
Yes, yes, shockingly, I know.
Yeah, and I hit it right. I know. I know. Normally I'm a little more optimistic about that. And don't worry, I'm going to get back to optimism and Star Trek at some point during this program. Put the mark up there, guys. So the NIH study recently showed that these high rates of clinically significant insomnia, along with more stress, depression, anxiety, et cetera. So as the pandemic has waned a little, has that gotten any better, do you think?
That's a good question. And I think people are starting, as you and Dr. Hawkinson mentioned, I think people are starting to become more hopeful. But I think that as we become more hopeful, we also are kind of looking around going, okay, this is what we're left with. And some of those people that have fragmented families now from losses during COVID, whether that be divorce, death, all these things that we have watched in front of us, I think it's going to take a while before people are able to fully pick up the pieces and move forward as if this, hadn't been a part of our lives.
Yeah, isn't that true? Wouldn't we love to have it not be part of our lives? The NIH research also kind of referred to, they did refer to sleep loss during this time during the pandemic as a second pandemic. Is it really that wide? Is it really that severe?
Yes, I think so. And I will say initially with our study was done back in August of 2020. And the reason that we did our study is because myself and the other authors included all reportedly waste time on social media. And we're scrolling on it at night. And that is termed as doom scrolling.
Is that what I heard you just say?
Initially in the pandemic, that's what we were doing, is looking for news and such on Twitter specifically. And then we came up with this idea that if we're doing this, looking for news, and sadly it was all disturbing news, who else is doing this? And so that's why we decided to do our study. And that's what we found. That was the first place that people were going for their information, for data, for suggestions on how to get through this. And I think that just was sort of a snowball effect in terms of sleep loss.
So, okay, Dr. Stewart, here's the hard question. Why does grief and anxiety wake me up at night? Why can't I have grief and anxiety and still sleep? What's going on there?
That's a fantastic question. $1 million question. So I often tell my patients that any underlying issue with mental health, whether that's anxiety, depression, bipolar, you name it, any sort of mental health issue, it will creep into your sleep eventually. And so, I cannot deal with sleep issues in the clinic unless we have dealt fully with mental health issues. And so I think that we have seen the data, even before the pandemic, that stress and anxiety and burnout in the population at large is there and it's prevalent. And then you add a pandemic onto it and, it's going to impact your sleep. You're going to have decreased sleep, which is in turn going to impact your mental health. And I think I mentioned on our last segment that I often describe mental health and sleep issues like an old married couple, and it's, if one's unhappy, the other's going to be unhappy. And if one's happy, the other's happy. And so it's sort of this yin and yang. And, if we've got to deal with both of them to make both of them happy.
It is a hard question, isn't it, to try and do all those things and to get sleep during these difficult times. Well, anything else we haven't covered, Dr. Stewart, that you want to mention this morning?
I would just mention that I know we mentioned in the last segment, but exercise and eating healthy are probably two of the most important things that folks can do for themselves just to try and keep their mental health in balance and in check. And in doing that, hopefully that at a minimum will help them with sleep.
And what do you think about meditation?
I think it's great. I know there's a lot of online apps for meditation, and my husband and I actually either in the morning or in the evening do a quick 5-minute meditation, and I think it's really calming. And so I think it's a fantastic idea, and I would highly recommend folks look into it.
All right. Well, that sounds good. And finally, long haul syndrome. Is sleep loss a part of that?
Yes, most definitely.
So all those young people out there, another reason you don't want to get COVID-19, so get your vaccine, because you don't want to have long haul syndrome interfere with your sleep, and it sounds like it does. Go ahead.
It does. It does. I mean, I will say from a personal experience, one of my dearest friends, and she's a physician, her whole family got COVID. There was some anxiety to getting the vaccine because it was unknown and they didn't know what all was going into it. She and her husband both got COVID. Her 3 young children all got COVID. And her husband, who's in his early 40s, is now dealing with long haul syndrome, and he's having some cognitive issues. And it's an unfortunate situation, but it's something that I almost could have predicted would have happened. And I was trying to encourage my friends and close family to get the vaccine and get it soon. And this unfortunately happened. And so now, I have someone very close to us that's dealing with this exact thing.
Yeah, tough things. Something else you don't want, Hawk, I think.
No, exactly.
All right, so let's turn and see if there are questions from the community. Jill.
Oh, yes. They're not disappointing today at all. I'm going to start with Elaine, though, because she's on topic and it's a good time to ask her question. Her question for Dr. Stewart is, would you do a sleep test at this time or just stick it out through the pandemic?
So that is a wonderful question, and I thank you for that. To clarify sleep tests, so there are 2 main types of sleep tests. One is a home sleep study, and the other is an in-lab sleep study. Those are for diagnosing either sleep apnea or some form of what we call hypersomnolence or insomnia, or sorry, not insomnia, narcolepsy. And so those are not to diagnose insomnia. We do not need a sleep study to diagnose insomnia.
You just know if you have it?
Yeah, if you have it, so there's acute insomnia and chronic insomnia. Chronic insomnia is something that someone has been dealing with for more than 3 months. And acute insomnia is something less than 3 months in time. And so the treatment for both of those are different. But I would recommend seeing your primary care physician or making an appointment with a sleep physician to go over those certain treatments for both of those. But you do not need a sleep study for that.
My follow-up question just for me is,
Sure.
if I have acute insomnia and I don't treat it, does it go away by itself or does then it become chronic?
Great question. I don't know the exact percentage data-wise, but I do believe that the majority of it, if not treated, can turn into chronic insomnia, because that's what I see in majority in my clinic is chronic insomnia. And it can be detrimental for people to deal with. And like I said earlier, with mental health in general, it kind of can offset and off balance even regular mental health. And so then folks end up dealing with mental health issues long-term.
And then Cindy wants to know, can young people, adolescents, can they suffer from insomnia during this time?
Absolutely.
It's funny. I think insomnia is indiscriminate in who it approaches. Again, this is one of those diseases, not unlike SARS-CoV-2, that doesn't care who you are, how much money you make, what color your skin is, where you live, how high the altitude is where you live. It can get you. Yeah, it does not matter. It's because of the factors that we find. I do think it's, in some ways, it is more prevalent in communities where there is more underlying social stress on an ongoing basis. So especially, I think folks who are economically challenged, job loss, et cetera, living in large communal settings. The same things that coronavirus has also affected disproportionately. Thoughts about that, Dr. Stewart?
No, I would agree with that. But I would also add frontline workers of any kind, whether that be, the postal service, the folks in the grocery store, the folks in healthcare, like all teachers, all of us in the front lines, all initially had a scare of going to work. And now, we're worried about making sure everyone gets vaccinated and the like. So I think that, frontline workers in general, I would put into that, not just, the communities that are affected.
Right. Now we've got some questions that are on the virus and the vaccine. Judy wants to know, my daughter is 15 and she is chomping at the bit to get the vaccine. Do you think she will get one before school starts in the fall?
Hawk, what do you think? I was bold. I said yes, but let's see.
You know, the way that these trials are moving for pediatrics and younger people, I would say I think we'll have some data soon.
Well, and
I would
actually
say
at
yes.
16, you're already eligible for Pfizer,
Yeah.
right?
Well, depending
So
when
you
she
get
turns
those
16.
Yep,
Yeah,
yep.
exactly. But it's still 15. I think there's a real good chance she'll be eligible. Yeah.
And I think the data is going to show, because Pfizer's already said preliminary data has shown great effect
Yeah.
in those under,
Yeah.
what was it, 12 to 16, was that it?
Yeah.
Yeah. And so then you got like Moderna's doing the same study and J&J is doing the same study. So I think in the long run, we'll be giving vaccine down to a very young age. That's
Yeah.
my guess. And there's a question of timing. What we're hearing is that many people believe a lot of that data will be out before the fall. And then it's just a question of making sure we get everybody vaccinated before the fall.
Yeah, and I think, you know, looking at the safety, I don't see or envision a lot of mechanistic reasons why the safety would be different in the children.
Right.
And even young people down to 14, you know, immunologically and how their immune system acts is probably very similar to those at 18. Again, not a pediatrician, but, you know, I think by that time you have a good, robust immune system that you have created, you know, since birth. So I think a lot of those mechanisms and those immunologic cascades and pathways and the way we fight virus and bacteria is going to be a lot of the same mechanisms.
Yeah, and I think the Pfizer-BioNTech, the vaccine, I think that vaccination, and again, this is not, we've not seen the data, it's what they are reporting. And by the way, I learned something this morning on that podcast.
Yeah.
And the podcasts in the New England Journal of Medicine about coronavirus are free and open to the public. And they're actually, they're meant for the public. And so I would encourage people to listen. But they specifically address this question of why are the drug companies talking so much about and giving all these press releases. And it turns out that when they know information like this, there's an SEC requirement that they do release that information. I didn't know that.
Oh, okay.
So that was part of it. At any rate, Pfizer-BioNTech said that the vaccine appears to be even more effective in the young. And so
Great.
if that's true, then and they did not find side effects. And so they're going to submit the data into the FDA for an early use authorization for, am I right about 12 to 16? I think I am.
I thought 12 was one of the
12 to 16 was
different
their
break
age
points on
group.
different trials, but 12 is one of the major ones. Yeah.
Yep. So my guess is that person will have a vaccine available to them by the time they go back to school in the fall. That's my guess. It is a guess. We don't know it obviously today, but I think that's the way this is going to roll.
Mm-hmm.
Melissa has a COVID and sleep question. It's kind of combined. If I'm reading this correctly, her husband was in the hospital for a week from COVID and is almost fully recovered. However, he has gone to the sleep clinic and he needs to go back again. Now he has loss of breath at night when he's trying to sleep. And she wants to know, is that been linked back to COVID when he was otherwise healthy? He wasn't apparently having trouble at night, and now he does.
All right, Dr. Stewart, probably a lot of questions a lot of other variables we need to know the answer to from that.
Yes, I would agree. I think, well, one of the things that we are seeing with post-COVID patients, depending on how ill they get, is some fibrosis of their lungs. And so if that was something that the patient dealt with, I would imagine that would also impact them during their sleep and breathing in their sleep. Because we do know from sleep in general that our oxygen levels dip down slightly at night, our blood pressure dips down slightly at night, and that's all normal sleep. And so depending on the depth of their lung that's impacted from post-COVID, that could certainly play a role.
Other questions out there, Jill?
Yeah, we do. Jean wants to know, how do COVID vaccines compare in terms of total protection to state-of-the-art vaccines like measles and smallpox?
All right, Hawkeye, that's a great question. What do you think?
Yeah, well, I would say that those aren't state-of-the-art. Those are old technology. Again, measles, mumps, rubella, live virus vaccines. Influenza can be an inactivated or killed virus or a live virus vaccine. The mRNA vaccine, but I would even say, to an extent, the Johnson & Johnson vaccine, where they're putting that spike gene into that other virus, is more state-of-the-art than, say, some of those others. And again, I think you have to look at the trials and the data. You can't compare one trial to another. The viruses are totally different, or if we're talking about the pneumonia vaccine, there's two pneumococcal vaccines. Those are against bacteria. So I think it's very hard to compare one to the other. Even the shingles vaccine is quite different. It's a subunit of the shingles virus, essentially. So I think all these vaccines are so different, apples to oranges. You really can't compare. But we have to look at the specific vaccines themselves and also look at the trials that they conducted to get their data. Again, the mRNA vaccines looked at 2-dose trials. The Johnson & Johnson vaccine looked at 1 dose. So I think you can't even compare those trials together. And so that's a very difficult question to answer for those reasons.
In general, I think, isn't it safe to say that at least the Pfizer, BioNTech, and the Moderna vaccines, those look really good? I mean, those have outstanding results.
Yeah.
That's the ones we know the most about. It looks like J&J is going to be really good as well. The single shot looks good. We got to see their 2-shot data. Interestingly, the single shot data now coming out about Pfizer and and Moderna suggests 80%, which is even better than J&J's single shot data. So, it's interesting that those are doing so well. To your point, one of the challenges is that coronavirus in the SARS-CoV-2 mutates a lot.
Yeah.
Some of the other vaccines that have been historical and have done so well, the virus didn't mutate, so it's easier to vaccinate against.
Right. And, we know,
except
like
influenza, which turns out to be not just it's a fairly
that's what I
effective.
was going to say,
Effective.
measles, mumps vaccine, that looks like it's 97% efficacy. So you have a small percentage of people who still get disease, even though they got the vaccine. And we've seen that, especially during some of the mumps outbreaks that we've seen that have been going on. But to your point, if you look at influenza vaccine, that vaccine efficacy of causing any disease from influenza, maybe 30, 40, maybe up to 50% some years, but it's difficult to tell. So I think as far as if you're comparing just the amount of protection against any disease whatsoever, these mRNA vaccines and maybe even the Johnson & Johnson vaccine have shown that they are better than, say, if you compare it to influenza vaccine.
It was interesting. If you remember back when we looked at this initially, we said that if the initial goal was to get 50% reduction in hospitalization and death. Well, we have a 100% reduction in hospitalization and death, and a 95% reduction in even having symptoms. I mean, they're crazy good. Much better than influenza.
Yeah, absolutely. So hopefully that answered that question. But very complex question.
It actually is a complex question. So apples and oranges, but still really good.
And Melissa said, too, she just wrote in while she was listening that her husband is a police officer, and she thinks he caught it while working with the public. That is so tough, and we really appreciate
it. Is.
Yeah,
that's why you want to be vaccinated.
That's why we want to get our first responders, those people that protect us, get that vaccine, protect yourself from, even if you do get ill, you don't have to miss, days work. There's a higher chance that you won't have to miss any days of work if you get the vaccination.
Kathy wants to know. Oh, sorry.
That's okay. I think part of the hesitancy, at least from the friends and colleagues that I know that have not received the vaccine yet, is that it's just so new. We haven't seen an mRNA vaccine before, and they don't know how that would compare. And so I think, Dr. Hawkinson, you mentioned, the difference between different vaccines, which is excellent. But I think that's the big hesitation, is that no one's ever seen something like this before. So are we really supposed to trust it?
Yeah, even though the technology's been around for 10 to 20 years, and isn't the MERS vaccine, isn't it a mRNA?
Well, they were working on that platform, but they've also worked on mRNA vaccines for CMV, which is a very common virus that most all of us probably have residing in our body at some point. mRNA vaccines they've looked at for RSV, for Zika, for Ebola. So again, the platform isn't new. But I would say, we can put a little piece of the RNA in there so your body can create a spike, or we can inject a live virus into you, because we know we have live virus vaccines, and that's the measles, mumps, rubella vaccine, and people have gotten those without any problems. So I think you just have to go look at it different ways, but we do understand that, especially more data now, that these vaccines are definitely safe.
Yeah, science. Okay, well, we've said before, faith, hope, and science. Weave those together. Very powerful. Go ahead, Jill.
Sorry, Kathy is asking, are any of the vaccines available in preservative-free doses?
Yeah, I don't think any of them have preservatives in it. That was a major issue and a major point in some of their press releases, or some of the other maybe FDA or scientific data, but I don't believe any of them have preservatives in them.
Some people have reacted to ethylene glycol or not to gosh darn it, what am I trying to think of? Miralax active ingredient.
Yeah, the PEG.
Polyethylene glycol, yeah. And maybe they're thinking that's a preservative.
Yeah.
Talk to us a little bit about what that really is. Because it's not technically a preservative.
No, and I think, the information and the stories about that have kind of died down a little bit, so I don't know if they've gone in a different direction, the investigators, when they're looking at these. Polyethylene glycol is a common substance, and a lot of people will take it on a regular basis, on a daily basis, to help keep their bowel functions normal. We use it a lot in or similar products when we have to prepare you for a colonoscopy, and at that point, you're getting it in much higher doses than you would in the vaccine. Any of these chemicals which we have seen in the vaccine, and they are available to us on a daily basis, such as the polyethylene glycol, which is in Miralax, you are getting in much higher doses than you ever would be in the vaccine as well. So.
Yeah, but so just to make the point, it's not technically preservative. There was some thought people were reacting to it. That has really died down now. The only other real side effect vaccination, Moderna's vaccine does look like there may be delayed skin hypersensitivity, but that goes away within days, not a big deal. The question about blood clots, especially in the central nervous system blood clots, that may be a little bit more of a concern, and I think that this morning even some information identifying it as like HITS or something like we call heparin-induced thrombocytopenia, that some of the issues around the AstraZeneca vaccine appear to be related to that, and there may be some increased incidence. We weren't sure if it was really the vaccine or not, but now they're saying, gosh, there may be a link. There's some very preliminary data saying there's a drop in the number of platelets after a Pfizer-Moderna vaccine, but they're very slight and not clinically significant.
Yeah.
So I think this is going to turn out to be mostly nothing, but a little bit. We just have to watch, especially the AstraZeneca vaccine, I think. Around
the VIPIT, that vaccine-induced prothrombotic state, essentially. It does get difficult to investigate these types of small amounts of adverse events, but we know that they are doing deep dives into all these cases to get more idea of what's going on and the mechanism behind that. But also remember, blood clots can be caused by other medicines, such as hormone therapies that women may be on, or birth control or something of that nature. But we certainly want to get to the bottom of this so that we can, and the company can present the best data, and the FDA can present the best data to us so that everybody understands the risks.
Okay, a couple of more questions. Katya and Isaac are asking about the Michigan folks. There was 249, I guess, that were fully vaccinated, and then they tested positive between January and March, and they had 3 people die. And they just wanted to know, what do you think's going on there?
You think, Hawk?
Yeah, I'd have to see the article. I haven't seen the article. So again, just testing positive for the disease after vaccination is not unheard of. We know that happens.
Yep. Especially if you've just had a shot and you're within that first 2 or 3 weeks after that shot, you should expect to be positive.
What I would be looking at more is the data behind those people that were hospitalized and the deaths, and really kind of deep dive into that and get some more information about that.
And here's what we know in our own hospital, folks. Remember that we were having 25 to 30 new acute diagnoses a day. Now we're down to 0 or 1, and that's with 85% of people vaccinated. We used to have about 100 people out cumulatively with COVID symptoms and or exposure, et cetera. Now we have just a handful. So there is no, in our own population, our community of about 15,000 here at KU, it is just a remarkable difference and how much better we've done around our own positivity rates.
Yeah, and I would say also we do have a multidisciplinary group here at the health system that will be looking at identifying if you have been vaccinated or not, if you are hospitalized with COVID, and then eventually working with the state to determine why is that. Is it a typical variant that we know of, or a typical strain, if you will, or is it one of these variants that concern whether UK, South Africa, Brazil, California, New York? So we do have a multidisciplinary group looking at that for those persons that have been fully vaccinated as well.
I think we have time for one more question,
okay.
And I hope that's not upsetting to Kelly and Nancy and Jeannie and others. I see your questions. You sparked great controversy. Or not controversy, conversation, not controversy. And I will get to these questions tomorrow, I promise. I'll put them at the top. But I'm going to give a last question to Dale because we have Dr. Stewart here, and my heart goes out to Dale. He says they have a age your family member who goes to sleep well, but is wide awake at 2 a.m. He's takes very little caffeine. He's, really trying to take care of himself, but he's desperate to sleep through the night. Any advice on why he's waking up every day at 2 a.m. when all he wants to do is sleep through the night? And what would you suggest that he do?
Thank you for that question. I see patients like this often. And so, number one, I would say talk to your primary care doctor or make an appointment with a sleep physician, because I think that there are a lot of different factors that need to be evaluated to get to the bottom of this. But I think it sounds like he's dealing with insomnia. And depending on how long he's been dealing with this, then treatment for chronic insomnia is probably the direction that I would suggest looking into. However, he would need a full evaluation, preferably by a sleep physician that would be able to kind of help him work through all these issues.
It can be frustrating.
It is got to be frustrating.
Absolutely.
Yep. Hey, tomorrow, ophthalmologist Dr. Ann Wishna joins us to answer questions about the impact of COVID-19 on eyes. COVID-19 patients suffer common eye problems. She's going to walk through those complaints and help us put it into perspective. We have a great ophthalmology department here at KU, and I know I'm a patient down there, so I've got a lot of experience with them, and I think this will be a really helpful and informative thing. Final thoughts, Dr. Stewart, from your standpoint today. And again, thank you for being back on our program today. I know we're going to need to have you back. Lots of questions about sleep. I have a lot of questions about sleep.
No, thank you, Dr. Stites, for having me. I'm thrilled to be here and thrilled to share information that can hopefully be helpful with the community.
Yeah, you did a great job. Thank you for that.
Yeah.
Hawk?
Vaccinations are still going to be our way out of here. We want to continue to talk to those patients and those people that are vaccine hesitant. Talk with your doctor, your medical provider. Ask all those questions that you want to ask, because, sometimes we don't have the answers, but a lot of times a lot of people have those questions. So we've been able to answer them in the past, and we're happy to answer those. Especially now with the rising amounts of variants. We've seen other countries in Europe that have doing much worse than we are as far as hospitalizations and death. They haven't had the ability to get the vaccine to as many people as we have. Vaccinations are the way out of it, and it is getting better, and we are able to vaccinate more and more people every day. And so that is a good thing, if we kind of wrap it up from Cody's original question.
Yeah, for sure. And one of the things that was mentioned in that podcast I referenced earlier today was that the United States didn't do a great job initially in our public health response around COVID-19, but we have done a pretty reasonable job here of trying to get these vaccines out. Our biggest problem is not enough vaccine, but now as vaccines are becoming more plentiful, what we're going to need are more of you to put your arms out and let us help you. And to that point, I want to encourage everyone listening to tell your friends, family, and neighbors in Johnson and Wyandotte County that we have 8,000 open appointments to fill. You got to be from Wyandotte or Johnson, or you have to work in Wyandotte or Johnson County. Either one will do it. We have 8,000 open appointments to fill if you want to come get a shot. You need to work or live in Johnson County or Wyandotte County. You have to live. Let me try that again. You have to live or work in Johnson County, or if you're from Wyandotte County, you have to live in Wyandotte County to get those doses. You do not have to be a patient of the health system now. We are opening up more broadly. For our patients who have MyChart access, you can go to MyChart and make an appointment. It's very easy. If you don't have MyChart access, or if you're not a patient, you can go to kansashealthsystem.com/vaccine to get an appointment. Or you can call 913-588-1227 if you're internet challenged as I am. Just use the phone number 913-588-1227, and we will help you get that appointment to get a vaccination. We want you to show us your arm so we can all be safe and be safe together. This is a really special time because we are emerging from the darkness and we're seeing the hope. And as we do that, we are reminded that we've kept the faith, we've worn masks, we've tried to take care of each other in the hope that science would get us to the reopening of our country safely. And that's exactly what's happening right now. So come and get vaccinated, and remember that even until you're vaccinated and for a while thereafter, there may still be no place like home. But the next best thing is a vaccine clinic where you're going to roll up your sleeve, show us your arm, and take a step into a better future. We'll see you tomorrow.